Of course, these new changes have resulted in adaptation for trainees, not only changes in surgical technique, but also changes certainly in the UK of various unwelcome time restrictions, which I'll go into a little more in a moment. When I first came to Maidstone in 1981 as a general surgeon, I was reminded of this eminent surgical figure, Astley Cooper. I found that the first patients I had referred had things like sebaceous cysts. Indeed, my secretary said, "Are you a specialist in sebaceous cysts?" And of course, the GPs, quite wisely, were trying out the new surgeon with something simple. And it reminded me of Astley Cooper, who at the time of King George IV came to London to sit at the feet of John Hunter, but also to make his name as a surgeon. He was quite socially skilled as well as surgically skilled, and the king was persuaded to ask him for his advice about a tiresome infected wen, or sebaceous cyst, which had troubled him for quite some while. And Astley Cooper skillfully removed this sebaceous cyst and made his name. He was thereafter surgeon to a succession of monarchs, not only George IV, but William IV and Queen Victoria. So there's a lot to be gained from doing something simple well. Little sketch in the early days of various staff in the operating theatre, and I'm told that the back view of a surgeon is usually the commonest and most recognizable one, and the little person in the middle is me. And at that time, I was establishing my career as a general surgeon and had been trained, as was the case in those days, in many different specialties. So before I came to give this address today, I went back to my operating diaries for 1983, when I'd been in post for a couple of years and was getting established. And I frankly was quite surprised that I'd managed to pack so much in. But the relevance of this slide is not only to show how hard we worked in those days, but also to illustrate the enormous variety of surgery that we were expected to undertake. At Maidstone in those days, we had no urologist, and I had done quite a lot of urology in my general surgical training. So we busied about getting some decent endoscopic equipment, Stort's telescopes with Hopkins rod lens systems that virtually made subsequent laparoscopic surgery possible. I taught of breast surgery, endocrine surgery, upper and lower gastrointestinal surgery, vascular surgery I found was really not being performed at all in Maidstone, and so I was keen to introduce it. I was quite an enthusiastic vascular surgeon, as you can see from the aortic aneurysms and femoral popliteal bypasses I had done by then. I've always had an interest in pediatric general surgery, so I managed to fit a bit of that in too. I went then to look at the work that my successor had done during the last year. And you can see he's an upper GI surgeon. And in fact, virtually all these procedures were performed laparoscopically or thoracoscopically, including the esophagectomies. And this shows the enormous change that has happened over 30 years in terms of subspecialization, as well as the development of minimally invasive skills. And these changes have made an enormous difference to our patients, improving outcomes not only because of the skill and the technique, but also because of a new way of working that has been a team spirit of working with not only other surgeons, and it's now quite common for surgeons to work in tandem, but also with oncologists, of course, and radiologists who provide such superb imaging and helping in particular stage malignant disease. So all this has resulted in huge improvements in outcome and quality of care of our patients. We mustn't forget our anesthetic colleagues. From the early days of ether, when actually the surgeons promoted the use of general anesthetics, to the current days of sophisticated anesthesia and even more sophisticated ITU care. We've been able to do procedures that just simply wouldn't have been possible on patients who would have been previously not at all able to withstand the sort of large procedures with the previous high mortality. And some of you may recognize the back view of another well-known Sri Lankan here, my colleague Sam Dezoiza, consultant anaesthetist, who's, in spite of lengthy operations with lots of stresses, managed to have an extraordinary number of patients survive major arterial surgery in particular. Thank you, Sam. Now, things haven't all been rosy. In recent years, we have had problems with hospital-borne infections and antibiotic-resistant bacteria. And I think that we have tended to become, perhaps, with the security of antibiotics, not as careful in our everyday habits as we might be. And we've had to go back to this obstetrician and his thoughts on hygiene. Semmelweis was an obstetrician in Vienna, they're actually Hungarian, and he, as many of you will know, found that the cause of the high incidence of puerperal fever in his hospital was due to poor hygiene on the part of the medical attendants and medical students who didn't wash their hands. And he demonstrated that the simple washing of hands reduced the incidence of puerperal fever dramatically. Semmelweis, sadly, was not the most skillful and tactful of men in the social sense, and his colleagues were rather offended by the suggestion that they themselves were the cause of so much illness and death, and hounded him out, and he returned sadly to Budapest and led a rather dismal life thereafter. But Lister was much more skillful and sophisticated a man in explaining to his colleagues the importance not only of hygiene but also of antisepsis. And we're needing to revisit this now that it's clear that not all bacteria are sensitive to antibiotics. And so this is an old lesson that we're relearning in the UK. Another eminent surgeon, and also relevant to this college event, is Lord Moynihan, who not only introduced the use of surgical gloves into Britain, another obviously aseptic technique advancement, but also took a very keen interest in the development of training at the Royal College of Surgeons, persuading Buxton Brown to buy Darwin's old house at Down as a research facility, and setting up many other training facilities at the college, as well as putting forward the idea of an association of surgeons, which eventually flowered after the Second World War. So training is a very important part of our role as surgeons. And in the days when I trained, and indeed when Lucky trained, our training was a little haphazard. We were peripatetic surgeons. We moved around. We were dependent upon the support of previous bosses to get the next job. We could be working at one end of the country one day and have to rush down to the new job and take over the on-call by 9 o'clock the next day. And for our families, certainly, it was a pretty stressful business. So moving gradually over the years from no control, we have seen change in surgical training, which has been very positive in the setting up of regional training schemes. In McCall, Lord McCall first proposed it at Guy's, but it didn't really seem to take off just at that moment, but it was picked up by some of his trainees in the South East Thames. And we started what was then called the Continuum Scheme. But the whole thing rapidly expanded over the country and became known as the Kalman Scheme. And this was really a very good innovation in that we were able to take a trainee through his paces in a district general hospital and then move on to more specialist units, particularly able to target the desires of the trainee for some particular subspecialty training. But in the UK, suddenly, we've reached a point of too much control. The training rotations continue, but in rather more central controlled way. And the European Working Time Directive has seriously limited the period of time that a trainee can actually spend working, and is still, I'm afraid, a problem that we have to overcome and you don't have to worry about here in Sri Lanka. However, in this new era of training, particularly in minimally invasive surgery, units are springing up that allow for telemedicine in a big way. And the International Minimal Access Centre for Surgery at Maidstone, set up by my upper GI colleagues, has really now superb facilities, not only for showing the techniques from theatre to the training unit, but also to units all over the globe. So we no longer need to take our trainees, as I did, the surgical registrar to Uganda to see training there and for them to learn about our style of training. We can relay it over the ether, if the anaesthetist will excuse the term. And so, thank you again.